This video is on pulmonary embolism. For the causes of pulmonary embolism, it usually arises from a venous thrombosis in the pelvis or legs. The clot will break off and pass through the veins and the right side of the heart before lodging in the pulmonary circulation, causing pulmonary embolism. Other rare causes include right ventricular thrombus after a myocardial infarction event, and also septic emboli after a right-sided endocarditis, and it can also be caused by fat, air, or amniotic fluid embolism, neoplastic cells, and parasites as well. These are some of the risk factors of pulmonary embolism which we have to look out for when taking history of the patient. For example, if the patient had a recent surgery or had history of thrombophilia, a recent event of leg fracture which may cause fat embolism, prolonged bed rest or reduced in mobility, malignancy, pregnancy or postpartum, or also medications, for example, oral contraceptive pills or hormone replacement therapy, and also especially if the patient had a previous history of pulmonary embolism. The clinical features of pulmonary embolism can be divided into symptoms and signs. This depends on the number, the size, and distribution of the emboli. Small emboli may be asymptomatic, whereas large emboli are often fatal to the patient. For the symptoms, the patient will complain of acute shortness of breath, where they felt breathless, pleuritic chest pain, hemoptysis, where they cough out blood from the lung, dizziness, and also syncope. So when the patient presents with these symptoms, we have to ask about the risk factors of pulmonary embolism that I have mentioned just now, and also ask whether they have any past personal history or family history of thromboembolism. Some of the signs that we have to look out for are pyrexia, cyanosis, tachypnea, which means increase in respiratory rate, and also tachycardia, increase in pulse rate, hypotension, raised JVP, pleural rub, and also pleural effusion. We should also look for signs of the cause. For example, look for signs of deep vein thrombosis, which could have caused a pulmonary embolism. For investigations, we can do blood tests like full blood count, Bill's and creatinine, and also arterial blood gas analysis, which may show reduce in both PaO2 and PaCO2. D-dimer is one of the tests for pulmonary embolism. And this D-dimer test is only performed in those patients without a high probability of pulmonary embolism. If the D-dimer test is negative, it excludes pulmonary embolism with those with low or intermediate clinical probability. This one I will explain more about it later on, where there is a scoring system for this pulmonary embolism. So if the patient has low probability of pulmonary embolism, we can perform D-dimer test. However, the positive test does not prove the diagnosis of pulmonary embolism, and imaging is required. So the recommended first-line imaging modality is CT pulmonary angiogram, which can show some of the clots down to the fifth order pulmonary arteries. Other investigations include chest X-ray and ECG. Chest X-ray may be normal, or it may show oligemia of the affected segment and also dilated pulmonary artery. Sometimes might show some pleural effusion as well. ECG may also be normal, or it might show tachycardia, right bundle branch block, right ventricular strain, and also the classical S1Q3T3 pattern, but it is quite rare. So moving on to this Wells criteria, which I've mentioned just now, it is a clinical scoring system to predict the probability of a deep vein thrombosis, which is one of the causes of pulmonary embolism. So there are a few components over here, which includes active cancer, paralysis of the lower extremities, recently bedridden for 3 days, or having a major surgery recently, localized tenderness, swollen leg, calf swelling, and also others, which you can see over here. So we add on the score, and if the total score is less than 2, the clinical probability of DVT is likely, whereas 2 or more is unlikely. For treatment of pulmonary embolism, we can give anticoagulation with low molecular weight heparin and also start warfarin. So we stop the heparin when their INR is more than 2, and then we continue the warfarin for a minimum of 3 months, where we aim for an INR of 2 to 3. Thrombolysis of the massive pulmonary embolism can be done, and we should also consider placement of a venous cover filter in those patients who develop emboli despite adequate anticoagulation. For prevention of pulmonary embolism, we can give heparin to all immobile patients, and also prescribe compression stockings and encourage early mobilization. So before the operation, we stop hormone replacement therapy and also oral contraceptive pills. If the patient has any family history of thrombophilia or thromboembolism, we should consider investigation for thrombophilia as well. That's all for this video. Thank you.